אצלי יש רק לב. הנה, כזה. יש לב.
We are pleased to have the next, this month talk of the Aufzien Center for the prevention and treatment of Parkinson's disease. And this month we have the honor to have Professor Dafna Ben Bashat as our speaker. Dafna, who is a physicist by her background, is working for many years in the Sagol Center for Neuroimaging or Brain Research here in Ichilov, and has been heavily involved in new techniques for understanding brain disorders through imaging. And for the past several years now that we've been tightly collaborating on developing new technologies to understand Parkinson's disease from diagnosis to progression. And Dafna has gained a lot of experience in this new and evolving field of using imaging to early diagnosis and following up patients with neurodegeneration. So it's an honor for us, Dafna, to have you with us and share with us your perspective on this, the role of MR in Parkinson's disease at all stages. Thank you. Dafna, את צריכה לפתוח את המיקרופון.
במיוט.
אוקיי.
Okay. So first, Neil, thank you for inviting me and giving me the opportunity to give this lecture, and really for the many years of a very pleasant, fruitful collaboration. So we wish to all of us many more years. So I want to talk about my expertise is in MRI and what is the role of quantitative MRI when we talk about the diagnosis of Parkinson. So in general, what is the role of imaging in Parkinson? And we can change the word imaging. I think it's these slides relates to if we talk about any blood test, any molecular biology. And if we're talking about the role of imaging, it's relevant to most disease, whether neurological disease, oncology problem. So the first task or the first role is really for diagnosis. And we need to be specific, we have enough specificity for differential diagnosis between different similar disorders. And especially in Parkinson, I think one of the challenges is to have it for the early diagnosis, because we know that that the pathology developed at least a decade before with all the manifested clinical signs before. But if we want to be able to follow up and better understand and maybe prevent the disease, we want to be able to detect it before the clinical symptoms and it appears and diagnosed is given. In the future, we want to be sensitive enough to follow up disease progression, and there are some studies that I will talk with the attempt to follow up disease progression and to monitor personal response if we have for any DOPA therapy, if we have in the future other therapies. So maybe we want also to be able to do a patient stratification if there will be different drugs that we can that will be available. So in this talk, I will say what is known in the literature and present two studies of our group or performed here in Tasnak. So what are the challenges? And again, it's relevant for everything, but it really makes us complicated to study with imaging, is that the clinical heterogeneity, and there are many subgroups. And if the subgroups are not clean enough, so we may mix different groups. So there's the Parkinson with and without mild cognitive impairment. Is there different imaging patterns? If we're talking about dementia with Lewy body or without, if just Parkinson, whether it's a overlap syndrome or different syndromes, if we're talking about multiple system atrophy. So all this mix, it's a disorder that we try to mix and find specific imaging markers, which really challenge in these studies. The different age of onset, the rate progression, the variability in response. So if we're talking about disorders and there are many groups, many patterns, maybe not one root of pathology or only one mechanism, and we try to put everything on one basket and find something, this really makes it difficult. And if we are aimed to find early markers at the prodromal phase, so in general, in the studies, there are two main groups that we're using as a group for risk, subject at risk, and those are with the genetic mutation. And here we focus mainly on the LARC2 and the GB, but there are other genes. And many groups focus also on subject with the REM sleep behavior disorders, with the RBT. And then we try to see whether we can see any imaging patterns in those groups. If we're talking about the group with genetic mutation, those who carry any gene mutation, there is a big question whether we do accept to see any endophenotype to this gene, even if the disease does not develop, whether it's inherent in the imaging pattern or just change if the subject developed the disorders, develop Parkinson. And this, again, when we take a group of subjects at risk, either with RBD or with the gene mutation, and we say that these are having the prodromal phase of the disorders, we might mix subject because the prevalence who will develop Parkinson is highly variable between studies, and these are between 30 to 80, depends on the groups, like I talked, the heterogeneity of the group. And so we probably have some ceiling or just hide some results if we make everybody together. So the only way is if we have long-term studies and then just retrospect divide those carriers, but this requires many years. So that's the problem when we study this group. Although they are at risk to develop, we don't always know who will develop, who is really having already the pathology. And for that purpose, the group that they develop the likelihood ratio that maybe put us more or maybe quantify the likelihood ratio of any subject to develop the disease, and then we can just pick up those who have genetic mutation, have other preclinical symptoms, and they are more likely to have Parkinson, and then we can study them. But this is a complex group that we want to focus them, but it's not one clean group of subjects. And everybody is talking about imaging biomarkers for PD, and there are a lot of studies, and you can see that every group that find any marker, any difference between group, then they come and they said, okay, these are biomarkers, and you have biomarkers for diffusivity, and you have biomarkers with the resting state. And I think this term is overused or not very accurately used, because there is there is a group called the QIBA of the RSNA, of the Radiology Society of North America. They call the Quantitative Imaging Biomarkers Alliance, and they aim to quantify all imaging all imaging data. And their objective is to characterize and derive from in vivo image measure. And they try to standardize this, and they work because if we want to define a biomarker, it has to fulfill many very strict criteria. It has to be quantitative, but it has to be repeatability, meaning if I scan a subject a few times without any expectation for the value to change, it should be same. I should get the same values. It should be reproducible between systems. It must be precise, reliable, sensitive, and specific for what I want to diagnose. And there's a lot of attempt to define imaging biomarkers based on PET, SPECT, MRI. And for that purpose, there are many groups. The only way really to face this problem is using multi-center studies, as really done by PPMI, by Biogen. This is the only way that we can define, have marker that is sensitive in MRI, but really having it defined as a biomarker. And DAT-SPECT is a potential imaging biomarkers, and currently is the gold standards for the diagnosis of Parkinson's disease, and it is very sensitive. But the problem with that is that there is no one way or standardized way how to measure it and how to analyze it and quantify. So if you compare values between papers, between sites, it's not that I said I got value of 6 and it will say anything to anybody else. And currently in clinical practice, DAT-SPECT is still diagnosed subjectively, not even quantitatively. And also the FDA warned that warned that it can be misread and interpretation is performed entirely by eyes. There's no hard numbers. And so DAT-SPECT has the potential to be biomarkers. It was shown to reduce that uptake in striatum in about in the prodromal phase in about 20 to 40% in subjects with RBD. It was shown also to be reduced in asymptomatic carriers of LRRK2. So it is sensitive for the diagnosis of the disease. It seems to be sensitive to be during the prodromal phase. However, it is expensive, it utilized radiation, and having this as a standardized modality for longitudinal routine examination for subject at risk doesn't seem so realistic or so useful and applicable practically. And for that use, many effort is done to use MRI. And I'm a favorite of MRI, this is my expertise. And the main advantage of MRI is that it provides a 3D information and multi-parametric approach. It's really a lot of dimension that we can have a lot of information, and information that in the macro way visualized, it does take or characterize microstructural properties of the tissue. So even if we talk about regular structural information, we can study using volumetry, the atrophy, cortical changes, structural volume of a different structure. So this is just by the conventional imaging. If we're talking about injection contrast agents, we can talk about permeability and breakdown of the blood-brain barrier. And currently there's an effort to see whether impairment of the BBB has a role in Parkinson's disease. Diffusivity study using diffusion or diffusion tensor imaging. And this information can indirectly detect cell size, quantify myelination, can be sensitive for any axonal injury, fiber organization. So it really provides a lot of information. If we're talking about quantitative MRI on the basic physical parameters of MRI, that indirectly we can quantify water content, maturation, iron accumulation, and I will talk, when I present what is known today, I will relate to the finding on those contrasts in Parkinson's disease. Perfusion, and that is maybe, it's not maybe not be so relevant to Parkinson, but is very relevant to other parameters. But if we talk about permeability, and then on a regular conventional imaging, we just say there is permeability or not. But if we can be able to quantify permeability, again, it might have a role in allowing toxin to enter from the blood vessels into the cells, onto extracellular cells. And of course, also a lot of studies looking at functional MRI and functional connectivity, which I'll be less talking in this because I guess there will be a dedicated lecture about what is known on functional activation and functional connectivity in Parkinson's disease. So what are the challenges if we go now for MRI? First challenge is that if we look at the MRI of patients with Parkinson, it looks normal. So by naked eye, we cannot say anything. We can have a subject, like you see in this image, that the DAT uptake is significantly reduced. Any neurology or radiology will say that this is a DAT uptake, DAT spectrum of patients with Parkinson. But if we look at the MRI looks normal. So we are looking for a very, very subtle changes. It's not like in brain tumors, it's not like in a brain lesion. We're looking for very small things. If we are interested in having quantitative analysis, we're also talking about small structures. And if we have error in measuring something, and if the structure is small, error becomes bigger. So this is another challenge, how we measure, how we quantify different structure. And MRI, because it has so many parameters and so many vendors and so many sequences and a magnetic field, there is a large variability in acquisition protocol, in data analysis, how we present the method, how we report, which structure, which template we use. So all this variability makes it difficult because I cannot really compare my values to other literature values in most cases, because if there are differences, they probably acquire the data differently, analyze it differently, use a different statistical models. So that's why it's so necessary to have a multi-center studies with the reading centers. What are the tools that we have to analyze the data? Because we're talking about small structure, we want to go to quantitative. So we can, for volumetric analysis, we need to do segmentation methods. And again, there are many methods that we can do. There are many tools, free tools, non-free tools that we could use. We can quantify the structure within the brain. We can quantify surface, cortical thickness. And if we're talking about connectivity, we can also look at structural or functional connectivity between areas. If we take any volume, most studies look at about the mean values, but then we miss a lot of information, because just having the mean values of specific structures, this is only one parameter. Sometimes the shape change, and this can something that can give us a lot of information. Sometimes the heterogeneity of the signal within this region gives us a lot of information. And all these features, statistical features on the volume that we acquired, is under the term radiomics features, and can give us a lot of information. When we have all this information, we need, or we want to use any statistical modeling, either to classify between patients and non-patients, or to classify between patients with MCI and without MCI, or to do any prognostic. So there is a lot of methods. One are if we just do any statistical based on voxel analysis, or if we want to have a lot of parameters from different modality and we want to use supervised or unsupervised method. And here also come the use of the deep learning and supervised. And lately, for the last year, I can see more articles using more advanced statistical modeling, how we combine all these parameters. Because of course, if we have more than one parameters, we might be more sensitive for the diagnosis, for the prognosis. So what are the findings today? What do we know today on Parkinson's disease? If we talk about conventional imaging, it's just on the volumetric. So we talk about reduced gray matter volume. And again, I cannot summarize all findings because it depends. One study did it with, like you see here, Parkinson's disease with RBD versus non-RBD, sometimes with RBD against control. And this is just one example. But in general, there is some reduced gray matter volume or cortical thickness. There is some reduced in the volume in some areas, but there are also some inconsistent results, like changes in substantial nigra volume. Sometimes some studies showed increase, some studies show decrease, and also depends, like I said, in the group. But the problem is that there are so small changes that are not repeated in all studies. And even if I show a statistical significance between group, it doesn't mean that on a subject level, I can say anything. So just looking at the conventional images, there are diffuse and some contradictory findings. If we're going now, maybe look at these tissue structures. Let's maybe have a look at the size of the cells, at the myelination, on fibers. So if we want to look at impaired tissue integrity and structural connectivity, so some study did show impaired impaired tissue integrity within the substantia nigra, but again, it's not consistent results. Some studies show connectivity data that quantify with progression patterns, but again, it's on the basis of group level, and we cannot really take it as a clinical tool to say, if I scan one subject, whether he has Parkinson's disease or whether he's a control or whether he has RBD, or depending on what I'm looking. So also when we look at diffusion or diffusion tensor imaging, we have diffuse finding and heterogeneous results. If we are trying to take this one back even, can we see any differences in those two groups at risk with the RBD and with the genetic mutation? So in RBD, one study did show some early signs of Parkinson's disease. One study here performed by Dafna, we did not find any diffusivity in gray or white matter in LARC2 carriers. So maybe this is not sensitive enough for early diagnosis of PD. If we're going now, let's look at the T2 and iron, because we know that iron has a important role in the development of Parkinson. So to quantify the iron, we can have T2 star, or what we call quantitative susceptibility imaging. And it was shown that narrowing the substantia nigra and T2 can be sensitive, and maybe again, biomarkers like all studies say, but again, there is high variability. So we do see that there is some evidence. The problem is how we accurately, reproducible, and on a standardized way, quantify it and use it as a markers that can be used on different sites in a clinical use. If we are going after just both FLASH and QSM are more qualitative, if we want to go to quantitative, then we really quantify the T2 star. T2 star is a parameter that represents relaxation time of the water molecule. It's a properties of the tissue, and it's correlated with iron accumulation. R2 star is 1 over T2 star, and we do see significant more T2 weighted hypointense signal in the substantia nigra in patients with PD compared to control. And it is also with the mechanism that we expect that PD related iron may serve as a robust in Parkinson. And for that, there is another sequence that was not even recently, a few years ago, was introduced, the neuromelanin. And the neuromelanin is a product of the dopamine metabolism that accumulate with age in dopamine neurons of the substantia nigra. And there are two cases that we can see an absence or reduction in the neuromelanin, both if we're talking about newborn babies with inefficiency in the coordination of movement, and also in Parkinson's disease. And you can see here on these pictures of the brainstem, and those white signals, those very small white signals are the neuromelanin, represent the neuromelanin in a healthy subject. And you can see that the signal reduced, maybe with volume reduced in Parkinson's disease. So it is very sensitive, but as you can see, it's a very small structure with very bad SNR. And if we want to quantify it and make it see how sensitive it is, a challenge. And many studies recently used neuromelanin, and I'll present you some results of ours as well. And it was suggested as a potential biomarkers in clinical studies. All those multi-standards of Biogen and PPMI adapt this sequence. But what are the limitations of this sequence? First, scanning time is long. Scanning time is about almost between 9 to 10 minutes. It is long. And as you can see, brain coverage is very small. We just look on the very very specific part of the brain, in the midbrain, because all the signal, the place that the neuromelanin is accumulated is very small. Signal to noise is very low. So if I want to quantify it, I have a problem with the SNR. And the results are highly dependent on acquisition, because there are some protocol how to acquire the data, and mainly and also on analysis methods. What the advantage? It is high sensitive, and there is a joint forces of many multi-center studies to develop a standardized protocol both for acquisition and analysis. What is important to understand that when we look at the T2 star, where iron is deposited, you can see the red nuclei and we can see part of the substantia nigra. But if we look at the neuromelanin areas and where we are interested to see increasing T2 star, increasing increasing the iron, there is no complete overlap from what we defined as a substantia nigra based on the T2 star and what we define based on the neuromelanin. You can have here a nice presentation of the volume, that there is only part of the volume is overlap. So again, how we define the area that we are looking for the T2 star or for the neuromelanin, what is the threshold that we define it, just different analysis methods significantly affect our results. So just to summarize what is known today, so if we are interested and we are for early prediction, we have, it's not easy to define this. It's a very rare, very unique and cohort of having subject with LAR2 or GB or with a RBD, but we need to know how to treat them because there are no one group. And if we want to have a quantitative measure, we need to understand how we make it, what are the assumptions that we do, how we analyze, and we have a lot of conversation, how we quantify each structures. And there are many factors that we need to take. And again, like I said, the PPMI, Biogen, there are some other groups really try to join forces and to standardize all this. So now I want to present two studies from our group, one on the DAT, which was the gold standard, and then we said, okay, how we quantify the DAT and whether we can see any differences in patients with in subject with the LARC2 but non-manifesting. So this was one study. So what we took the DAT images, we quantify, we took a mask, and we took the ventral stratum and we divided the stratum to ventral and dorsal. And this was based on a K-mean, just it was data driven. And again, we can do it data driven, we can use template, many studies use template. In this study, we wanted to optimize the differences based on the subject themselves. And maybe then there is overfitting to our data, and maybe it should be performed on much larger cohort, and these things should be evaluated. Just to emphasize that on a visual basis, just visual inspection by radiologists, usually what they will see is reduction in the dorsal striatum uptake in patients with Parkinson, and they cannot really detect or identify reduction in the ventral striatum. But when we quantify it, we can see that patients with Parkinson's disease, if we compare them to non-manifesting non-carriers or to non-manifesting carrier, as expected, there is larger differences in the striatum, in the dorsal striatum, but we also see significant difference in the ventral. If we try to look now only on the patients, only on the subjects who are carriers, and maybe we can identify patients, subjects who are carriers and later convert to Parkinson. And in this case, we had 3 subjects that converted to Parkinson. In 2 of them, you can really see that, and this DAT was performed before they were diagnosed with the Parkinson disorders. So 2 subjects, theoretically, we can say that they are already patients, that the disease is already progressed. And 1 subject that was rescanned even after she was diagnosed, she was swelled, there was no differences in the DAT. We couldn't see any, we couldn't identify her as a subject, as a developing Parkinson. So if we have quantitative, we'll get the high sensitivity also for the ventral striatum, and hopefully, if we know more subjects who convert to Parkinson, we will be able to quantitatively say they already have they already developed Parkinson. Another study is, as I said before, if we rely just on DAT imaging, it's invasive, it's expensive. So all attempt is how can we have MRI, and then this will maybe substitute in the future DAT, and then subjects who are at risk, either with RBD, genetic, or any other risk factors, can be scanned routinely using the MRI, and we can find early signs for Parkinson's disease. So in this study, we wanted to take the neuromelanin, and as said, it looks a very promising methods. But in this study, we related to various parameters of the neuromelanin, and we want to assess first what is sensitivity to inpatients, and this has already been done. But what we wanted to do is to take not only the volume, but radiomics feature, like I said before, and also what will be the sensitivity of neuromelanin in patients or in subject at the prodromal phase. So in this study, it was the cohort of Biogen when they scanned the first time. So we had 46 patients with Parkinson, 47 healthy subject with healthy subject non-manifesting, but with any genetic mutation, 23 with GB, 24 with LARC2, and 34 subjects non-manifesting, non-carriers. They don't have any, they are relative of patients with Parkinson, but they don't have any known genetic mutation. We related to the likelihood ratio, taking what is the likelihood ratio of any subject to develop Parkinson. So as you can see, there is no meaning for Parkinson's disease, but for the non-manifesting carrier, the mean likelihood ratio was higher than the non-manifesting non-carriers. So this is just what the cohort that we used. And the first, we wanted to analyze the DAT, because if we aim to, in the future maybe, to replace or to be correlated with the DAT, we wanted to analyze again quantitatively the DAT based on exactly the same cohort. So in this, now there is more accepted criteria to calculate what is called specific binding ratio, meaning we take the DAT, we normalize the values, in this case to the occipital lobe, and then we get value. And in this case, we did not relate to the entire striatum, but we divide it to the caudate, putamen, globus pallidum, and brain stem, because we thought that we may be able to see sensitivity in any pattern of progression of the disease. So that's why we divide it to different areas, and of course, left and right side separately. What we got, if you look first before this red square, is the differences, and this is as expected. There's no new findings in this, that we got differences between Parkinson's disease and non-manifesting carriers or non-manifesting non-carriers in all regions, including the brainstem, which was lower SNR. The SBR values are much lower in the brainstem. Still, we got significant results. But if we look at the putamen, and again, this is what originally we expected, that the putamen will be more sensitive. Here we also get differences between non-manifesting non-carriers and non-manifesting carriers. And again, the non-manifesting carriers is a mixed group. Some subjects probably are in the prodromal phase, and some are healthy subjects that will not develop. So even with this not clean group, we still get significant findings. Another thing that we wanted to see in this group of the non-manifesting carriers, is there any difference between LARC2 and GB carriers? And in this case, we got only the putamen, significant results only within the putamen. And what we see that just in the LARC2 subject group, we got significant difference compared to the non-manifesting non-carriers. And This is something that's going with other studies that they show that LRRK2 patients have more prominent gait disorders, and here we get more prominent reduction in the DAT uptake, and as you can see in those values, both on the right and left putamen. So it's probably support that it's a different progression of the disease, more prominent in this group. What we want to now is to do similar analysis and see what is the sensitivity of the neuromelanin. So first we need to quantify the neuromelanin. What is nice in this sequence is that we can extract both the neuromelanin signal, but in general, we can extract also by specific analysis of the same data, some T2 star values. So what we did is that we took these two maps, we defined those VOI, one of the neuromelanin extracted from this sequence, and one we took the red nuclei, which again, previous studies show reduction in the T2 star in the red nuclei in patients with Parkinson, and we took the substantial nigra based on the T2, but we also calculated the T2 value, T2 star values within the volume of the neuromelanin, based on the neuromelanin. But we didn't want to stay only with the volume or only with the mean intensity value. And then we applied a lot of radiomics features. We got about almost 20 features. I'm just explaining the main three that we got results. For example, the contrast really measured the local variation. What is the variation? If we talk about correlation, we talk about measure of gray matter linear dependence of brightness on neighboring pixels. And if we talk about homogeneity, is what is the high value or how constant is the image. So these are different statistical analysis, statistical parameters based on the values either of the neuromelanin or of the T2 star. And if we are expecting, for example, that the neuromelanin won't just be equal with equal intensity within the entire volume, but only part of it will be reduced signal, then it will be manifested in our homogeneity parameters. So this is just to get more information from what we have. So we got a lot of results, and I'm trying just to summarize the main results, is that we did as expected, and like similar to other study, we got reduced neuromelanin signal in the patients with PD compared to healthy subjects non-carrier, and we got also reduced in the volume. So these are two independent, both the signal and the volume, and most study used usually either signal or volume. Here in this study, we did not find any significant difference for the T2 star, which we did expect to get because it should go along with the neuromelanin, but maybe it was not sensitive enough in MRI. However, when we look at radiomics feature, then we did get some several features also relating to the T2 star. So it's not just the T2 star reduced, but also the heterogeneity. And these are the three parameters that I talked before, the contrast, correlation, and homogeneity, both of the neuromelanin and of the T2 stars that did show significant differences between groups. When we talk now, what is the correlation between MRI and our features, that SBR value and our features, we got several correlations within parameters, mostly with the putamen, as we saw before, which is probably more sensitive to the disease, but there were significant but weak correlations between 0.25 to 0.32. So there is some correlation, but they are not very strong, meaning we don't see exactly the same thing. So we wanted to take it a step further, whether we can, now that we have many features, maybe we can use it to classify to use it as a classification between patients and the healthy subjects. And maybe we can identify those subjects at the prodromal phase who later converted to Parkinson's disease. So when we took, and this is thanks really to Moran for all this work she did, is to to evaluate various models, and like I said, the statistical models or the classifier that we use, and it's always a lot of question which feature you put in the classifier, how you defined it, and we played with this a lot. And for that, if we just wanted to, these are machine learning, it's supervised. We teach the classifier what is healthy subject and what is Parkinson. So if we want healthy subject, we took only those who are non-carriers and are not at risk with LR below 6, who are not at risk to develop Parkinson. And in this case, we got about the accuracy was about 0.8, which is much above incident level, which is 0.5. And it's nice for if we're talking about classifiers for nice papers, but it's not as sensitive enough for to be a clinical tool. So currently we are working maybe to add, maybe the good approach is to add other parameters and not just rely on this neuromelanin and T2 stars features. So just to summarize what is known and what we have done, I think first that there is overuse of the word biomarkers in general and imaging markers specifically. We need to have it quantitatively, and we need to have it with all, responding to all criteria for repeatability, of reproducibility, standardized it. And so if we do want to suggest the biomarkers, we need to stay with the standards that requires any difference, any markers to be biomarkers. I think that as MRI, that seems very, very sensitive. As we saw from what is known on conventional imaging, what is known on diffusion, what is known on functional, the studies do show significant difference between groups, but it's not a clinical use. I cannot take one subject and say if he is a patient or if he is in prodromal phase or if he is a healthy subject. So we need to combine also all parameters and maybe improve, because 0.8 sensitivity is not good enough for a clinical use. We must relate to radiomics features. I think just relating to the mean values or to the volume is missing a lot of information, and we know it from many other studies of computer vision that relating to radiomics feature, we can say so much above what a radiologist can say, even studies that show that we can identify genetic mutation in for example, in brain tumors. And we need to use advanced statistical models on large cohort. And only if we do all this, we might be able to have some parameters or some approach that we can say, okay, we have a biomarkers based on MRI that can substitute DAT in the future and be sensitive for early diagnosis of Parkinson's disease. And with that, I just want I didn't write name because then I probably miss many names. So just to thank everybody, because it's a huge effort of so many people of the Laboratory of Early Markers that really lead this project, of Biogen, of this Aufzien Center, and my group and my center that people just, so really thanks to everybody. And thank you for your listening.
Dafna, thank you very much for a very clear and concise lecture. That was really wonderful, very informative. We do have one question, so before we start taking from the audience, I will read it. The question is, when it's on the chat, when measuring volume, how are individual differences taken into consideration? And these measures would be different between non-PD.
It depends how you take individual differences. Sometimes we do normalize, and this is always a question, whether I should normalize the volume of the substantia nigra hippocampus to the total brain volumes. So usually we try to normalize it. Some volumetric of some volume knowledge on brain structure is pretty known because it's taken in the ADNI of Alzheimer's. So really thousands of people are there. Maybe most important is changes in time. What is the trajectory of changes? Because the problem also, and I didn't emphasize it enough, but Parkinson really getting if it's not on younger people, so they're older, so just normal aging also have brain changes. So its problem is to see very subtle changes on top of many other, which probably are just normal aging, or maybe they have other disorders, or again, you mix things. You mix Parkinson, you mixed it with MCI, you can mix it with RBD. It's really a mixed things of many things, and it's a good question. It's we try to normalize. I don't know if I answer it, but.
Thank you. Uri, I see you're raising your hand. Go ahead.
Thanks. Great talk, Dafna. So I wanted to ask whether, if you have the data, did you try to go to the next stage of correlating between the different parameters and the different measure, and maybe getting a much stronger, way of differentiating between levels of sickness or disease severity?
You're talking about adding different imaging modalities, like adding diffusion to these parameters, or?
It already measured different parameters. So whether you try to, if it was done on the same patients, you can now try to have multiple measure from one person and get a much stronger effect.
Yeah, this is the main idea or the main target of our centers, and I think of Biogen, having all the same information from different centers. This is the approach, how we add, but each just analyzing neuromelanin is a huge project. How you combine, yeah, but this is the main idea, how we get a multi-parametric. This is the, we haven't done it yet, but this is what we intend to do. Everything is clear.
It was very clear, actually. Moses, you have a question.
Yeah, thank you very much, Dafna. This is excellent. I didn't get it. What are you're aiming at? Is it a diagnostic issue that you're looking at, or is it something that relates to the mechanism that is relevant? In terms of diagnosis, I think you have, as you say, the accuracy is not very good. You did not show us what we would like to have are the PPV and MPV, the positive prediction value and negative prediction value. And I would also add to this that it is one thing to compare Parkinson patients to normal controls. This we can do pretty well. What we fail at is to differentiate between Parkinson disease and other movement disorders, for example, PSP and or MSAP or other disorders. I think this is still a good question. Will probably reduce the accuracy even further if I can predict. What you didn't talk about is the time factor, because these are progressive disorders. So I guess things at the early stage are not as prominent as they would be later on. And you've mentioned the age, but it's also the duration of the disease at which you look at it. And this is important also because if you can look at, if you can identify the progression of the disease, then this will be might be a very good instrument to look at factors, at interventions and whether they're successful or not. So before we can see whether a patient improves, whether you can see, you can show that over a year or 2 years, the rate of degeneration differs from what is expected, I think this would be of great help.
Okay, so first, thank you, because these are really exactly these are really good question, because exactly what the challenge that we face. Because if I try to remember the question, the first was that it's the differential diagnosis between Parkinson's disease and other groups. But sometimes the problem is that when you build a study, so people take exclusion criteria. For example, I think in Biogen, we exclude all this with dementia. And when we talk about Lewy body dementia, then we wanted to exclude the Parkinson. So people, unless we do the same protocol, what we try, it's not that we have 500 subjects on different group and have enough statistical power to identify between, but there are studies that took only Parkinson's disease with MCI, Parkinson's disease without MCI, Parkinson's disease with RBD, Parkinson without RBD. But again, because each study used different protocol, you cannot even compare everything together. That's why I came back that we need large cohort, same protocol, one reading centers. Regarding trajectory, this is very important and a good question. In this study, we are just analyzed time one of this cohort, and we have on the pipeline, I think next month, we are going to finish recruit, or they're going to finish scan this exactly same cohort after 1 year. So then we'll have the issue, can we study trajectories or differences between group maybe, and then we can correlate it with the disease duration. So this is exactly, like you said, is very important what we can say. When we look at the brainstem initially and we define some area, we thought, we hoped that we will be able also to see the BRAC mechanism, where it starts from the brainstem, then it's going up. Maybe we'll see first in the neuromelanin and only then in the DAT because it's going up. So we hope that maybe we were too naive. We even wrote a grant on it, which you didn't receive, that we will be able to see the mechanism. Now I'm not sure we will be, not with these tools. DAT is sensitive, MRI is still lagging behind. But yeah, it's a different question if you want to see the development of the disease, the prodromal or after, and after the disease, or just to see disease progression in patients, we will hopefully will have some results within a year.
Thank you. I have another question, if I may. Parkinson's disease is an asymmetric disease. Mm-hmm. Have you been able to see in any of these parameters asymmetry?
Yes, and you can also see it in many studies. I must say that this is something that in one way. Sorry. So we get some results, asymmetry results, and if you can see by the slide I show, people said, okay, we got this on the right, this we got on the left. There is no consistency on which side. And the problem is or a good thing with the brain, that everything that I can find, I can explain. So if I get you, I found it on the right side, you can say, okay, I find it on the left side. So there is lateralization. So people do find some results on the right, some results on the left, but there is no consistency in these findings. And yeah, and if you can relate and say, okay, this is right, but this is not what I expected, I'll be happy to get this feedback. Which side do we expect to see we change? Because I can show you on the relaxometry and the T2 star, we got it only on the left side. I don't know why. Maybe just bias of the data. Maybe if we enlarge the cohort, it will be on the left or right, or be both. So we do get, but this is in many disorders you get, even if the disorder is not lateralized. So this may be something we could focus more and see.
I have a question. Hi, Dafna. Thank you for a wonderful overview and also sharing our data on, and this is, as you said, this is a prospective study almost, that we are still collecting data prospectively on those subjects. We will be able to give some more answers. My question to you, Dafna, is first, the new technologies that will lead the field in the years to come, and what is the role of 7 Tesla MRI in future assessments?
I think 7T has is huge advantage. in terms of resolution and of course signal to noise. It maybe can teach us things that we can understand, and then, but we must then learn how to translate them for 3 Tesla, because if you want some clinical tool, 7 Tesla won't come a clinical tools within the next 5-10 years. It's much more expensive, FDA regulation, issues of people feel more headache or more dizziness. So we need to develop, it took time for the 3T to become routine clinically used in a clinical site. I think people do show, it might help show more patterns, more about mechanism. I think what Biogen showed us that they try to predict the signal from 7T can be nice. So maybe it won't be a break technology, I don't believe so, but it can improve our understanding. And for MRI, unless we get some really new sequences, the basic, I think maybe just being able to combine all parameters, and then you need to define them on very large cohort, and then have very reliable but advanced statistical models. We won't have any tool that really, tomorrow you can send me, okay, send this subject, tell me if he has Parkinson, and let's go to what Amos was asking. Listen, in 3 years you'll diagnose him, or just at the early prodromal phase, and in 7 years. So I think we have a long way to go to be there.
Thank you.
Sorry, I'm not more optimistic. Really.
The good thing that we are not doing good job in predicting how technology will be developed. These are jumps and not steady progression. So hopefully we'll be surprised.
Yeah, hopefully.
Okay, I think that's it for the questions. Anything more? No. So Dafna, again, thank you very much. That was really wonderful. We really appreciate it, and for you becoming part of our APPD community. I want to remind all of you, we have seminars about once a month. And on April 11th, we're going to be holding our annual, larger conference than we've had in the past. We're going to be celebrating World Parkinson's Day. And you'll be seeing very shortly, we'll be sending out a save the date. And I hope that you save it. It'll all be virtual this year. But I think we're going to see a lot of really exciting events there. Okay, everybody. Goodbye. Keep safe. It's windy out there. Don't blow away.
יופי, תודה דפנה, היה טוב מאוד.
בכיף, תודה.
Dafna, can you stay on a minute?
Sure.
Okay.